With that, we have a panel discussion, and I invite Dr. Sarah Hallberg as well as Dr. Samar Hafida for the panel discussion. May I start with my own question first to Dr. Sarah Hallberg? We have patients, obese patients, responding differently in metabolic terms, like some obese patients develop diabetes, some do not. And when it comes to low carb and ketogenic diet, have you seen that different patients respond differently? For example, diabetes patients with diabetes respond differently than obese patients without diabetes, or is it not different?
So I would say that a low carbohydrate diet can be effective for anyone who chooses to follow the intervention. So, I'll start off by saying what I said in my talk, which is there is no one size fits all diet. So we can't tell a patient what to do. We have to be able to present them with options and be supportive of the patient and their choices. And so what we have certainly found is that when patients are told, especially when they have type 2 diabetes, that they have an option to reverse their disease, a vast majority of patients are interested in that and would like to hear more and potentially begin that intervention. So for anyone who chooses to do it, whether they have type 2 diabetes or just obesity, it can work when they're supported properly. Who is it most ideal for? I believe it is most ideal for patients who struggle with type 2 diabetes. There we see just such dramatic changes in their health. And I know it has been mentioned by a previous speaker, the heterogeneity as far as the weight loss outcomes with a low carbohydrate diet. And that is true. There are patients who seem to be much more reactive and lose a significant amount of weight than other patients. But when it comes to blood sugar and blood sugar improvements, really what we see is that there is across the board improvement in anyone who chooses this intervention. So I guess my really closing on that question would be, for providers, it is critical to understand a low carbohydrate ketogenic diet and to be able to have a patient-centered discussion with your patients and present it as an option, because the health improvements, both with obesity and type 2 diabetes, but much more dramatically with type 2 diabetes, can be profound and life-changing.
Thank you. Shilpa.
Dr. Sarah, this is my question to you. So you said that you put patients on ketogenic diet for a period of 2 years. That's the length of time that you have put individuals on ketogenic diet.
No, we have put patients on. Our trial is 5 years. We just finished our 5-year data collection. So the data that we will be publishing is all the way out to patients who have been on a well-formulated ketogenic diet for 5 years.
And so do you grade carbohydrates at all, or you just leave them to about 20 to 50 grams all through 5 years?
It really depends again, on the individual patient. So our program is set up to be what we consider continuous remote care. So as Dr. Hamdi was talking about so many of the interventions, telemedicine and, connectivity is so critical right now in providing patients with support. And the way that our system works is that we are in constant support with our patients. Each patient is assigned a couple of health coaches to be able to cover them on the weekends, at night, times, when patients are eating and they need guidance. We have such a high touch program based on health coaches and physicians. There's an entire healthcare team behind each patient. And so if a patient puts in a biomarker that is unexpected. Maybe their blood sugar is high, their blood sugar is low. Rather than waiting for a patient to call up and make an appointment based on that biomarker, our team is gathering that biomarker data and actually proactively reaching out to that patient. And so the support there is absolutely critical. So a patient may get a contact from our health coaches or someone from our healthcare team even before they realize that there's a problem. And that is real support. So the health coach interaction is up to 2 to 4 times a day for patients. And the average medication change by physicians is 5 to 7 times for a patient who is starting a well-formulated ketogenic diet. In other words, when you start it, you need less medication. And that less medication can't be adjusted 3 months later in the office because you're going to run into hypoglycemia and a lot of safety issues. This needs to be done in really almost real time. That is critical for patient safety and satisfaction. So it's really a level of support that is able to be done because of the use of technology.
Thank you.
There is a question from the audience for Dr. Sarah. Is it a good idea to add SGLT2 inhibitor to ketogenic diet? And there's another. Okay, we'll go ahead with this question first.
Yeah, this is a great question and a really important one, because what we're seeing is that SGLT2 inhibitors now are indicated for patients outside of just a type 2 diabetes diagnosis. And we know there are plenty of cases in the literature, there are nice case series done, that a low carbohydrate diet potentially could increase the risk of the ketones going into a too high range with an SGLT2 inhibitor. Remember what I said from our talk, without an SGLT2 inhibitor, when you have type 2 diabetes, we're not concerned about this. However, when someone has a need for an SGLT2 inhibitor, this is where the support that I was just talking about becomes absolutely critical, because we're able to follow their ketone levels. And again, monitoring these biomarkers on a daily basis. So right now, I would suggest, that there are patients who the priority at this time with the data that we have is on the SGLT2 inhibitors. They can still be on a low carbohydrate diet, but there must be something in place to be able to monitor them very carefully. That's something that we have because we're, again, getting those biomarker data in on a regular basis and able to watch for any rise in ketones that is above what we would expect. And that must be in place for that to be done safely and effectively.
So there's another question on the same line from the audience. What is the safe maximum value for blood ketone in a medical clinic?
Well, really, there hasn't been any concerns in patients, again, not on SGLT2 inhibitors, not who are, patients with type 1 diabetes. We can get ketone levels up to even 5.0 in patients who are potentially doing a ketogenic diet for reasons outside of metabolic disease. It's really difficult to get anywhere near there if you are someone who's struggling with metabolic disease, which again makes this even more ideal for those patients. But take someone who's doing it potentially for athletic purposes, right? For distance running. They may have levels up to 5 post-exercise, and there hasn't been any associated, issues or safety concerns for those people. But again, when you're talking about well-formulated ketogenic diet, specifically for type 2 diabetes, as I said earlier, it's, really rare to see someone go above 2.0 millimoles.
Great. Thank you so much. I have a question. Okay.
You go ahead.
Okay. I have a question to Dr. Hamdi, sir. The fascinating patient-doctor interaction through an electronic media you have shown, And it's really has helped like nothing in times of Corona, where there was no possibility for the patient to come to the doctor's clinic or for the doctor to go at the patient's place. Is there any identified set of red flag signs that go to the patient, which alert the patient for the requirement of a physical examination? Because that is something that we cannot take away from the patient-doctor relationship. So how do we identify patients who do need to come for a visit? Not in an emergency, but even in a routine care.
A good history from your patients will definitely identify those people that you will need physical examination in them. Luckily, when we are dealing with type 2 diabetes and with obesity, there is minimal physical finding that we would like to evaluate, except for maybe neuropathy, maybe for foot ulcer, some of this stuff. But again, what you can see by your eyes can be seen by the camera. What is also interesting is that there are many ways now. So we're testing a device, for example, called the FeedC. And if you step on that device, it will send you immediately signal that you are at risk for ulcer or not, because it shows the pressure is deviating and so on. And it's actually much better even than clinical examination. Sensory neuropathy, they can be tested digitally as well. So there is a lot of opportunities that can be done, but I do need people to get an impression that this is a total replacement to physical interaction. I actually prefer that the first interaction is to be in person. You break the ice, you know your patient very well, but it doesn't require that this person that you know now to come to your practice each now and then and travel for long distance and spend that much cost to see you. If everything can be done, we are doing this seminar right now in a very nice way. I don't think that if we are traveling to India now and have all the hassle of the jet lag and the stuff, we'll be able to give a much better talk than what we are doing right now. So I think the future will tell us things can be done in a very nice way.
Absolutely no, because this was the first time in India that the telemedicine was made legally allowed. Because before that, the telemedicine wasn't, and it has really opened up new revenues of managing patients who are otherwise difficult to access.
I think this is a major benefit that we get from the COVID epidemic, that physicians and providers and patients, all of them have some degree of experience. And without that epidemic, I doubt this was to take like 10 years to be implemented.
Anjali, with your previous question, Anjali Bansi here.
Yes. Yes, sir, we can hear you, sir.
As you know, the previous answer was that those patients who are on SGLT2 inhibitor, where only the ketone bodies are to be monitored. But suppose somebody is doing a ketogenic diet, I mean, to monitor that person, is it a good idea to monitor them that they are with urine ketones or with the blood ketones? Should we measure it or not? And just to know the compliance of the person, whether she or he is doing ketogenic diet or not, can we measure it intermittently?
I'm sorry. So the question is, should you, if you have a patient who is following a ketogenic diet and is on an SGLT2 inhibitor, do you need to check ketones?
Not on SGLT2 inhibitor, only on ketogenic diet. Can we follow that patient with the ketones body, whether that ketogenic diet is really effective or not, whether body is making ketones or not, urinary ketones can be measured, or the blood ketones can be measured for that?
Yeah, that's a great question. And the answer is, in a perfect world, we would be checking ketones because it's a really great way to personalize the nutrition intervention. But the fact of the matter is checking ketones costs. And so you have to make a case-by-case decision on if you're going to be able to access ketone monitor and ketone strips. I think that we're going to have a real game changer in this as we find that companies like, Abbott, Dexcom are going to be coming out not only with, new and improved continuous glucose monitors, but that they are going to also be able to monitor ketones as well. So once we get that and the price point comes down and those become more available to the masses, I think that that is going to be a critical point of help in coaching patients on a well-formulated ketogenic diet, and patients just being able to again, learn their own individual metabolic responses. So I think that you can do it without checking ketones. It is absolutely possible. Ideally, checking ketones helps. And I think we're going to really have a game changer when it comes to continuous ketone monitoring as well.
Any comments from Dr. Shashank Shah?
In fact, I had a question to Sarah. We have many patients of metabolic surgery for diabetes, gastric bypass, and over years they have some weight regain, and probably it is unfortunate that they start attempting keto diet on their own. But I believe with the physiology, the fat malabsorption, and the entire intestinal mechanism being different, we do not have any evidence to offer keto diet or low carb diet to these patients. Any comments, any studies on using this after bariatric surgery?
So I'll tell you that I use it all the time post-bariatric surgery. Patients do very well on it. It's definitely, again, I'll go back to what I said before, patient choice, patient education. But I have used this in so many patients post-bariatric surgery, and I've not had any issues, with patients having any, malnutrition, issues with fat intolerance, because those can be that can be modified by just patient instruction and support. This absolutely can be used post-bariatric surgery with success. Do we need a big trial on it to see patients who have regained post-bariatric surgery if we put them on a ketogenic diet? What does that look like, and what does the data look like at scale? Absolutely, we need that research. But I can tell you that I do it on a regular basis, and patients tolerate it very well. Patient choice, though.
Just an additional comment. Many procedures which have malabsorption can induce diarrhea, more malabsorption, bowel disturbances if there is high fat intake, and even dumping, and sometimes hypoglycemia. And if fat is not getting absorbed in those patients after malabsorptive procedure, would the diet work like a regular diet, a regular keto diet?
You may have to make modifications. Again, I go back to the heterogeneity of everyone. And that is why, again, our health coaches are trained to really approach each patient as an individual. If anyone is having trouble at all, there are so many different ways that we can tweak the diet, tweak when they're eating, tweak, what they're eating, to make sure that it is tolerable. Really, it can be successful in these situations, but only if you approach each patient as an individual patient and not be giving a one-size-fits-all diet approach, even when it's a low carbohydrate.
Anjali, just one question to Dr. Samar. She summarized metabolic surgery extensively and very well, and a very good analysis. After having so much of evidence on long-term benefit, cardiovascular outcomes, Dr. Samar, are you looking at any activity, or do you suggest anything to improve acceptance and recommendation of metabolic surgery for diabetes, because still millions exist who deserve and need them?
Yeah, that is probably the number one barrier. That's why the figure is 0.5%, despite its impact. There are efforts done in each local area to spread the word among primary care physicians, endocrinologists, cardiologists, and other medical professions. But the acceptance rates, I think, are extremely low because of the clinicians' lack of understanding of what this procedure, can do for their patient. And then there's still a fear of, like you mentioned, Dr. Shah, the weight regain, which is a real phenomenon. But weight regain is, I would say, probably in my clinic, probably 50% of people that I see are weight regain after metabolic surgery. So I think in the coming years, when we have better tools, and the uptake of the GLP-1 receptor agonists and the other newer, very powerful medications that are in the pipeline for weight management, there probably will be more utilization of those in conjunction with metabolic surgery. But still, it's a big problem.
Can the chair, men and women, allow me to ask my colleagues, Sarah and Samar, 2 questions, if you don't mind?
Absolutely, sir. Please go ahead.
Okay. So first, I will start with Sarah. I know Sarah for a very, very long time. She's an advocate for ketogenic diet for many, many, many years. And I believe when we wrote our article together in New York Times back in 2016, we turned the table around that whole area. The title for that article at that time, which is an op-ed, which created a lot of controversy at that time, is old-fashioned diabetes treatment, a better diabetes treatment. And basically, we're talking about lowering carbohydrates based on the old definition of diabetes as a carbohydrate intolerance disease. And I'm still advocate for lower carbohydrates, maybe moderate lower carbohydrates, not very low carbohydrates. And the reason I would like to ask Sarah to give us her experience and input. One of the major criticisms of ketogenic diet is that we are not only losing fat. It is not just a ketogenic process. It is also a gluconeogenetic process where we will lose significant muscle mass. So glucose can be generated by ketogenic process, but also by gluconeogenesis by breaking down muscles. So what is your experience about this? How we can avoid it? And especially in places where the lean muscle mass is lower, like in India and some other places. We know that people beyond the age 40, they lose around 8% of their muscle mass every decade, which means that from 40 to 70, they lose around 24% of their muscle mass. By age 70, they lose 15% of their muscle mass. And as you know, losing muscle mass is catastrophic because now energy expenditure is lower, basal metabolic rate is lower, and even glucose uptake become lower. So how you will avoid this, and what is, if there is any body composition data had been done over 2 years and 5 years?
Yeah, we have that in our 2-year paper that is published. We have the DEXA data. And so, there is some muscle mass loss when someone goes from, loses a significant amount of weight. But we don't have any evidence that that is increased. In fact, evidence that it may be decreased, the amount of muscle mass loss with a well-formulated ketogenic diet versus other methods of weight loss. And so I encourage anyone to read the 2-year paper that we have published and on this, our 2-year results that looks at the DEXA data specifically.
And my question to Samar, how you see the non-invasive endoscopic surgery going on for bariatric purpose or for metabolic purpose? This is done by gastroenterologists. There are several procedures they are doing it right now, including sleeve gastroplasty. So how do you see this in the future? Are we moving toward more of endoscopic or gastroscopic intervention, or we will still continue to do the traditional way?
Yeah, that's an awesome question. So the non-surgical interventions for weight loss are, like you mentioned, the endoscopic sleeve, the duodenal surfacing therapy. We have varied balloons and the Aspire method for weight loss as well. So the biggest barrier at the moment is probably the lack of the cost and the lack of insurance, at least medical insurance coverage for these procedures. So we don't have the wide scale studies like we do for the bariatric surgeries. I think they are looking at the limited data that is out there. They show promise, and they have probably a niche in terms of who they would benefit. People who are very high risk for major general surgery would be one of them. Maybe perhaps post or pre-transplant organ transplant people who need to lose weight prior to their transplants, or high cardiovascular risk. In terms of metabolic benefits, at the moment, it's still the traditional weight loss surgeries that show the bigger impact in terms of diabetes control.
I have a question for Dr. Sama Rafida. Are you aware of any trials that say that the absorption and metabolism of anti-diabetic medications, or for that matter, other medications that we use, changes after the malabsorptive procedures?
I love this question. Yeah, this is a very good question, and the answer is no. However, the requirements for diabetes medications definitely goes down, so the need is less.
That's because of metabolic improvement, not because of absorptive changes. Okay.
Correct. I'll give you an example of a medicine that is, highly subject to variability in absorption. For example, levothyroxine, we know has to be taken at a certain time on an empty stomach. And there are multiple studies looking at, is there a decreased efficacy or decreased bioavailability of levothyroxine after Roux-en-Y gastric bypass? And the answer is no. As a matter of fact, the requirements per kilogram goes down because people are losing weight. So there's no difference in absorption, even with Roux-en-Y gastric bypass. So, we have our nice injectable medications that are conveniently taken once a week. So they probably will replace many of the oral medications in certain people, of course, barring cost. So hopefully we don't have to worry about that too much. But that's a great question.
Thank you so much, Dr. Hamdi, Dr. Sarah Hallberg, and Dr. Sama Rafida. I think the questions are over, and I would like, because this is the end of the International Diabetes Expert Conclave 2021, I would love to have all the team, our chairperson, Dr. Sanjay Agrawal, the scientific chair, Dr. Neeta Deshpande, organizing secretary, Dr. Archana Sada, of course, me, as well as Shilpa over here, to express vote of thanks and take a leave from all of you.
First of all, I'd like to thank Dr. Osama Hamdi. We had all the while, been doing IDEC nodal updates and all about diabetes. For the first time, actually, we've ventured into doing IDEC obesity. And I would like to thank Dr. Osama, who's a very close friend. I think last 10 years, we've been working together and we've been interacting. So thank you, Osama. I think this entire program was conceived by you. And all the speakers have done an excellent job of delivering the lectures, extremely informative. And we look forward to have a physical meeting next year in Pune for that matter. And I would like to also thank Novo Nordisk, who's been very supportive of this program. Shri, why don't you come over? When we conceived this entire program, and I know she's interested in obesity, so I told her, see, we're doing this IDEC obesity. How would you like to support this? And she wholeheartedly welcomed this program. So thank you, Shri. I would like to would you like to say a word about?
No, thank you very much. This is one of our first forays into obesity, and I'm hugely enlightened at the end of these 5 hours. Thank you so much. Educational feast. Thank you.
Thank you for supporting us. And of course, I would like to thank my entire team. Ritika, please come over here. You're standing there. So who's really worked behind the scenes to make this entire meeting possible. I'm sure that we couldn't have had such a wonderful scientific meeting without all these people working so hard round the clock for, I don't know how many, 4 months, perhaps 5 months. And of course, I'd like to thank Vama Events, who've had the seamless, delivery of this entire meeting all across the platforms. They have done a marvelous job. So thank you, Vama Events and the team from Vama Events. I'm sorry, I think we've lost power over here for some reason, but I'm sure you can hear me. And I would like to just give this mic to each one of them to speak one word, just a few lines about what they feel about the entire meeting. So starting with you, Archana.
I think we learned so much and we are inspired to do more and more, have more and more relevant topics to reach out to more and more people. And we go back with new practices to practice in our own clinics.
Team IDEC is absolutely satisfied. This particular IDEC, each one has been better than the previous. And our whole team has worked so hard to bring this academic feast to the world of diabetology in India, and we have had overseas registrations as well. And it's been a fantastic experience organizing, listening, and learning.
Just now, Dr. Sanjay has said that for the last 4 months we have been working, but I would like to say that the next year's IDEC is already in my mind. So we have lots of questions which are unanswered this year, and we would be thrilled to work over them to get back next year.
So it was a great experience working together. And Dr. Sarah, I promise that I'm going to start doing ketogenic diets from tomorrow. I'm really impressed and I have a lot of questions. I'm going to take your email ID and I'm going to write to you. Thank you.
And the lady who knits us all together is Ritika. So your word.
Thank you so much. It's always been a pleasure to work with all of you, and I look forward to many more IDECs.
So with this, we'd like to close the IDEC meeting. Thank you, Osama. Thank you, Guillermo. I think I should mention also Guillermo. He's the heart and soul of this entire meeting. He was the one who's actually put it together right from the onset when we started IDEC 5 years back. So Guillermo, me, Nita, all of us got together and we've conceived this entire program. And this year, of course, Osama has joined us. So Osama, thank you. Guillermo, thank you for making this entire meeting such a successful venture. Thank you so much. Thank you.
Thank you, Sanjay, and thank you, Nita. I'm still missing the biryani and the gulab jamun. So.
We promise to give it to you. The only thing you'll have to travel the continents and come over here.
Yeah, good luck. Good luck.
Thank you so much, Osama. Thank you. Bye-bye. Bye. Good night.